Thank you. We did a little bit of a drawing before, and I lost. So I got to be the last speaker on Friday afternoon. I'm not going to talk for very long. I'm going to introduce myself. I'm going to tell you 3 stories, and then we'll have whatever conversation is left. But I appreciated that last panel, especially appreciated Dr. Polsky's comment there. All right. I am a professor of the practice of health policy management at the Bloomberg School of Public Health. I'm a former health commissioner of Baltimore City, former health secretary of the state of Maryland, about to be the former chair of the Health Services Cost Review Commission in Maryland, which oversees hospital payment, former principal deputy commissioner at the FDA. So most of my career has been in public health, the public part of public health, and then I have worked with all kinds of state and local agencies and federal agencies since I've come to Johns Hopkins about a decade ago. That's my background. So I'm coming from the public health perspective. So I'm going to tell you 3 stories. First story, I'm brand new at Johns Hopkins. And I'll just tell you the experience of going from the public sector to academia is a little bit like landing on a different planet. Nothing more so than the hiring process. Because in the public sector, the hiring process is like you interview people and you hire them. In academia, it's like people give talks, and to all the and you see who's competing against each other, and then everybody gives comments. It completely blew my mind. At one point, one of the people got up at his job talk, and he put his name up. Like if it were me, I'd be like, Josh, just want to be your colleague. Only thinking about the projects we can work together. And I'm like, oh my God, this is like a 3rd grade president election. He's doing an anagram with his name. I'm like looking around like, why is this so unusual? So I go to a job talk, and it is about the Malcolm Baldrige Award. How many people know about the Malcolm Baldrige Award? It's a big award for hospital quality. And the speaker is on the selection panel, and he's talking about all the work he's done advancing the Malcolm Baldrige Award. And he says, it's so quantitative, it's so rigorous. That's what makes it so special. These are the best hospitals. The patients are happiest. Everybody gets aspirin when they have a heart attack. They love the food, whatever it is. He's going through all the different things about the hospital. And so then he goes, I'm going to give you an example. And he throws up a hospital in Florida. I don't remember the one it is. And I'm sitting there, and I looked up the county that the hospital's in. Big headline, life expectancy falls. Cardiovascular disease rises. It was just a horror show. So I raise my hand, questions come, and I go, yeah, I'm just wondering how you take into account the health of the county before you say you've got this absolutely stellar hospital. And he goes, well, we do have an essay section that people can write about what they do for their community health. And I go, well, what happened to it? We're so rigorous, we got numbers, I thought that was the whole deal here, And he's like, well, it's kind of hard to measure. I'm like, is it though? Is it really impossible to measure? At this point, I see the chair of the department going like, it's his job talk. This is in front of all the colleagues. Give this guy a break. But basically, my position coming from public health is no hospital should feel like it's doing its job fully until its community is getting healthier, period, right? And I don't think it should unlock all of the financial benefits. I don't think it should be viewed as a great hospital until it is truly part of a healthcare system that delivers health, because that's what we need in this country, more health. We're doing terribly, by the way, overall, compared to the rest of the world. And so how do we get more health out of healthcare? How do we get more health out of hospitals? We actually asked that question, in part, for a project with IBM at the time. They had the top 100 hospitals project. Oh, and by the way, I did a paper where we looked at every hospital award. None of the major hospital awards really had community health as a major quantitative issue. I appreciate the Lown group doing its particular ranking, but none of the other rankings did that. We put together the first measure. And to put together the first measure for that, we did a public comment period. We got all kinds of comments. We put out a draft. We got more comments on the draft. And I think that I've been reflecting the whole time on what people have been saying here. There's a lot of an assumption in some of the discussions that I kind of pick up, which is you run the hospital because you got to run the hospital. Then the question is, what do you do with any money that you can make for community health? See, that's not how we approach this. It's what is a hospital that produces community health? And some people here have said, like, it's a lot more than community benefit. It's a lot more than community benefit. So first of all, we said there should be a measure of actual community health, and that unless it's, actually improving, could be life expectancy, could be maybe avoidable illness, avoidable hospitalization, something like that, which would be a good overall measure. Doesn't mean you're penalizing somebody, but like there should be a carrot at the end when everybody's working together and you're actually delivering what we actually want as a society. Then we had 3 other domains. The first domain, and we published this paper in a journal called Healthcare, I think. It's a pretty good journal. And the first domain was actually clinical services, which we have not talked about at all. There's a hospital that I know very well that we had a big meeting with people who were working on chronic obstructive lung disease, and they came in and they said, we're upset you don't have a smoking cessation clinic here. Like, do we know that every hospital that we know and represent has a smoking cessation program? One of the most important things for community health is to reduce smoking, and many of them don't. So we actually surfaced a whole bunch of things. I'll give the example of the one that was recommended, and we actually surveyed the top 200 hospitals under the IBM ranking. Just over half of them said they offered drug treatment with buprenorphine in the emergency department, a treatment in the middle of an opioid crisis that can reduce mortality by 90%. So, you have to start with the clinical services. Everyone's going, well, we're a hospital, we got to take care of people. But unfortunately, a lot of hospitals will think about their clinical services by how much they bring in, not by what their community needs. And you can talk to the advocates for pulmonary rehab, which is a service that extends life and is very hard to get for Medicare patients and others. Cardiac rehab, same thing. The services that communities need often aren't being offered, let alone the kinds of programs to keep people from coming back to the hospital again and again and again. So you can look at the paper. The way we looked at it was we identified and this isn't perfect, this was like 1.0, like 12 services that should be part of clinical care, and you got credit if you got like 7 or 8 of them or something like that. So that was number one. The second domain is kind of more in the community benefit realm, was a collaboration for underlying needs of people. And so that had to do with like housing, transportation, and those sorts of things. And we had a whole list of things that hospitals could do, and we gave them credit if they did some of those. But there was another category which we've only a little bit talked about, which is the hospital as a community institution. And so we've talked about maybe community institutions don't take people to court, if they're destitute. I mean, the story that really rings a bell for me is when there was a Catholic hospital that took a nun who'd taken a vow of poverty to court, for non-payment of bills, John Cohn's book. So that's a community institution kind of thing. But you also have minimum wage, you have childcare, you have other things that program for returning citizens from incarceration. There are a bunch of things that organizations can do. So if I think about how a hospital contributes to community health, I think about having measurements that they're aligned to at the community health level, clinical services that actually meet the needs of their community, partnerships to address the underlying causes of health, some of which we've talked about today, and actually acting like a really productive institutional partner for their community. All right, that was story number one. Story number two, I'm Health Secretary of Maryland, and somebody calls me and says, are you familiar with the community benefit program of one of the major hospitals in the state that I knew well? And I said, not entirely. And they said, well, they are sending a ultrasonographer to churches in Baltimore City. And when people leave the church, they offer them a free neck ultrasound on the spot. And if they have a certain degree of stenosis, they're signing them up for carotid endarterectomies. At the time, and I'm not a vascular surgeon, but at the time, the recommendations were you do not operate on asymptomatic carotid endarterectomy, and there's an operative mortality associated with it. So like doing screening of mass populations is not a recommended activity for this. So we call this at the health department no vascular surgeon left behind. Okay. They were screening people to bring them in for surgery that probably some of the people didn't need. We called the hospital. We wrote them a letter with some references. They stopped the program. And they said, but one person said the thing was the people at the churches loved it. You know, and I mean, if you think about it, if you think about how, you know, I can believe that, you know, but that doesn't deny the fact that it actually might have been harmful. It probably was harmful. I did meet one guy in a different healthcare system who said to me, well, when I got started in community benefit, my job was to judge the state beauty pageant. I'm not making that up. That was part of his job under community benefit. So to me, the question of community benefit has always fit into this bigger picture. We're trying to improve health. Where does community benefit fit in? There are absolutely fantastic things that hospitals do as part of community benefit, and we've heard about some of them. It's very hard to figure out. I mean, I appreciate Hussein's call for, you know, outcome data. Is this particular investment doing something? You know, that's a full employment program for public health faculty, you know, to investigate all of the impacts of these different programs, and some of them probably should be reviewed. But to me, it's you know, this has been a very interesting discussion, defining a little bit better what the categories are, but more importantly, aligning what the hospitals are doing with meaningful outcomes so that they can bring the full scope of what they're doing to bear. I see the community benefit as a tool. It's a means to an end, but there are other means. If you can get a policy change, you know, through lobbying, that may be as effective as $20 million spent on a program. You know, if you can increase the cigarette tax and get cigarettes out of, you know, clean indoor air laws, that might be better than a whole lot of other kinds of programs. So, you know, really making sure there's a strong alignment to community outcomes and seeing community benefit, which can be important as a means to an end, is important. And that gets me to my third story, and I'll be done. In Maryland, we do pay hospitals differently, and I see this as in a very complex way, what we do in Maryland. But for those who don't know, hospitals get global budgets. It's not fee-for-service. Fee-for-service to me means the hospital gets paid more when the community is sicker. Okay, I mean, I think that's basically what it is. It's a fundamental misalignment. Here we are talking about community benefit. We want the hospital to contribute to the health of the community, but we pay hospitals the big money when the community is sicker. So shifting off of fee-for-service gives you a fighting chance to say hospitals will be doing better financially when the community is getting healthier. The hospital gets a global budget no matter how many patients come in the door. And that gives an incentive, in theory, for more prevention interventions. And so I had a CEO in Maryland say to me, I just had 2 meetings today. I thought I would give you a call and tell you. The first one was with the finance committee, and they wanted to build a whole new building. You know, they're so excited. It goes back to that great presentation today about how, you know, building buildings tends to be a thing that people do. And you know, definitely boards, they like, you know, we're going to do a new building now. It's going to be another patient tower. It's going to be, and they were like, and I was just thinking, wow, you know, we don't have that much room to grow with our global budget. It's kind of hard. And then I went to the next meeting, which was our community benefit team, and they were talking about, you know, this project to put a clinic and a senior housing program, and they were going to reduce admissions, and you know, it was one thing after another. And I thought to myself, these guys are making me money. I need to get them to the finance committee meeting. Finance committee meeting, they're trying to spend money in a way that's actually going to squeeze my margins. We have to rethink, you know, how we think about financial investments in Maryland if we're going to be operating under a global budget. That was one of the good stories. I mean, they're challenging stories in Maryland too. I don't want to overstate it, but I do think that, in my mind, it starts with what the community health outcome you want to have. It's an expectation that hospitals will align to that and that we'll pay them to align to that, which is really important. And then community benefit is sort of the third leg of the stool, which are some expectations about the kinds of ways that they will put money to make sure that you can do that, they can be as effective as possible, but it's really not the whole thing. So those are my 3 stories. Thank you for the chance to talk, and I'm open to questions, but more generally, I want to give the opportunity to everyone here to, make kind of closing comments or take-home comments from the day. Thank you very much.
Hi. This has been wonderful and really thought-provoking. I work for a governor, and one of the things that I have found lacking in the discussion today is about costs for patients. And I'm just sort of curious about the room's take on some of these community benefit, both reporting and options, and sort of like the foundational structure of the program as baking in some of the costs that consumers are paying, that employers are paying, and that state Medicaid programs are paying. And I think earlier in the conversation, Dr. Anderson talked about how maybe these are not always the right players to be, right? They are not housing experts always. They are not whatever the sort of community benefit that they've landed on. They're not necessarily the expert, but we're shoveling money towards this, and Medicaid's paying for it, Medicare is paying for it, but I'm also, as a government, I'm paying for public health too. I think there's not this conversation about like, okay, but how does that price come down, and are we putting upward pressure on it?
I think that's good. I think one of the points that was made earlier, I'll just give a quick, but anyone can respond to anybody else here, is that most of the money we're talking about is actually going for clinical care. It's making up for gaps in the system. Relatively little is going for housing. It's like a teeny little bit, And, but it can be very helpful, particularly, for example, a hospital can identify people who are at very high risk for readmission, and it can be quite a good investment to work. Say in Baltimore, we've had hospitals work with healthcare for the homeless to set up supportive housing. It can be a very efficient investment for them to do that. And in fact, they work with the Medicaid program to set up the reimbursement for it. But I don't know that I think of community benefit as like lavish social services coming out of the hospital sector. I think of it as almost completely, in many cases, clinical services, and a little bit of the other stuff. So I don't see this as personally the private sector being fleeced, for that kind of thing. But I think ultimately a governor's office can set goals for the kind of health that you want, and then if you get better health, that should and lower costs too, then you're lowering costs for everybody that way. But I'm interested in what other people say to that. So, thank you.
I got the mic, so
Sure.
I wanted to tie that question in with something earlier. So again, I work at a local health department. This is going back now about 12, 13 years. There were no services at all for pregnant women with substance use problems in my entire region of the state. And we got a very small grant, and like all public health agencies, we are held accountable for every dollar of that grant. So we had our metrics, everything from how many substance use individual treatments every one of our patients had, whether they attended group. We had a threshold for how many prenatal appointments, because most of these women up to that point, this is back at a time where injecting heroin was the most common form of use. We were measuring the number of preterm births. We were measuring the number of women coming back after their pregnancy for postpartum contraception, including LARC, or long-acting contraception, because there were enormous numbers of repeat pregnancies in this population because they didn't go in for prenatal care. They certainly never went back for postpartum. So, the idea that hospitals can't actually account for the way they're spending money, to me, is garbage, because at a much smaller, less resourced agency, we do that all the time, every day, with every one of our grants. And at the end of our first 2 years, I could show that we had a $23 return on investment for every dollar that we got in grant funding. Most of that was because of decreased NICU costs. because there was such a dramatic reduction in the number of babies that had to spend a month in neonatal intensive care unit going through withdrawal. And we cut dramatically down on preterm births. And it was an estimate, that was the biggest chunk of the savings, but it was also an estimate of the number of future pregnancy costs, because 70% of our patients ended up with either an Explanon or an IUD after their pregnancy. And that doesn't even take into account all the savings on the social, on the police and law enforcement and prison side for people who did not end up getting arrested and going to jail. The vast majority of those patients are Medicaid. So, what was important to our state legislature was that $75,000 they invested in our program, the vast bulk of that savings was going right back benefiting the state treasury, because it was a huge reduction in Medicaid. So I would say that, again, as we look at community benefit spending going ahead, every dollar of this should be accountable. Hospitals have the capability of doing that. And we take pride in this. I think it also motivated us. We know there are people watching what we're doing. And I think, as human beings, that always is a motivator to, put that extra bit of effort and make things succeed.
Thanks, Larry. Other questions or comments? Anne, you do.
I just wanted to respond to your comment, because it resonates with me. And I don't think these are huge pressures on costs necessarily, but I think it's a very fair question to ask, are busy emergency room physicians the right people to be screening community people that come in? And, we are adding all of this, like, screen for this, screen for that. And you talk to the front line, and not only that, but then there's a code for it, a special code. It's got to get in the EHR. And we don't even know at the other end, does anybody get referred necessarily? And I think that's worth stepping back and kind of just revisiting who is the right institution, when it could be our public health department, or in the schools, a different setting. I mean, we have busy, backed up emergency rooms.
But why do we have busy, backed up emergency rooms?
Exactly.
We have busy, backed up emergency rooms because people can't get drug treatment. So they overdose again and again and again. The emergency room has to offer drug treatment. I know it may take a little bit more time, but it is the standard of care from the American College of Emergency Physicians. It is recommended by multiple medical groups, the National Academy of Sciences. But yet, only 53% of the top 200 hospitals do it. So I do think that there may be some things you have to have a clinical judgment on, but there are other clinical services that truly aren't being provided that are really important and actually can help address some of those problems. I don't think the right concept of a hospital is that it just takes the rest, the consequences of everybody else. I think it has to be part of the solution, and it can be. There's so many programs and studies that demonstrate that they can be part of the solution, and aligning that in the right way and resourcing it is really the challenge, in my mind.
I'm particularly also, you're very popular today. I'm also thinking about your observation and how the costs for patients have been part of the conversation, but a little bit off to the side, not really the point. And I've recently joined US of Care's federal policy and advocacy team, and our organization is really centrally focused on costs for patients, affordability challenges for patients, medical debt for patients. And something that a lot of this is making me think of is basically those savings that are generated from all of these really positive initiatives are excellent. And also, at what point do they go back into reducing costs for patients? And I think a question that I've been thinking of that makes me want to ask other people your thoughts on is, if we were trying to convince decision makers, policymakers, public health, anybody, to consider increased scrutiny or regulation or incentives or supports for hospital prices, which we know are one of the driving causes of high costs for patients. If we want to look at rising hospital prices, those are continuing to go up. Premiums continue to go up. Deductibles continue to go up. At what point do they come back down with these savings? And, if we want to look at hospital prices and encourage policymakers to consider looking at them, what aspects of tax exemption and community benefit do we point to?
Yeah, thank you. I mean, it sort of raises the question of cost as a driver for health more broadly in the community, because if healthcare becomes unaffordable, people lose insurance, and there are all kinds of other consequences. I would just to get to the micro level for a second, we looked in Maryland, we do have a 200% kind of rule. People can't get charged under 200%, and it's challenging sometimes to implement. But the people still get bills from physician groups, And since we adopted that, I don't know that we've seen a declining share of medical bankruptcies. So it's, this is definitely a complex problem. I do think that keeping people from the hospital who don't need to be there or could be avoided is the best way to avoid a charge wherever you can. But controlling the costs, I'll just point out one thing. Hospital prices contribute to rising costs for sure, but hospital prices are not the same as costs. Costs are prices times volume. So in Maryland, we control the overall budget for hospital services. And so if you really want to think about premiums, and it's important to think about the growth in overall hospital costs, which is a huge focus of our state for sure.
So now you've got all of us thinking about this question, right? So we were having this conversation earlier about community benefit purely as a measure, as a number. And if we examine community benefit in that way, to your question, there is no upward pressure or no pressure on health systems to lower their costs. Because if you lower your costs, your community benefit goes down, right? Because then your charity care, if it's looking at unpaid Medicaid, if we're looking at that difference between, what's covered and what wasn't covered, right? That number goes down because the cost went down. So there's actually this weird perverse incentive for hospitals and health systems to keep their number up and maybe provide more assistance to patients. And so then the question becomes, who gets assistance? How do you determine that assistance? And then you get it. And so the financial assistance policy conversation that happened earlier will get to your point, which is, I think, more about out-of-pocket costs for patients. But in terms of the costs themselves, lowering the costs, the CB calculation as is does not encourage that.
Thanks.
I just want to put a cap on what you just shared, because I made a comment earlier about the why of why our community benefit numbers are so high in the uncompensated care, lower in some of the other community health, social determinants of health areas. But just to that reason, cost is so high, and we know that it's medical care is so high, and we know that it's much higher than preventive care. And so that is one reason why it's just flip-flopped and will be until costs come down, which then benefit patients.
The cost of healthcare, right, is not just simple as what does it cost the hospital, right? Baked into what it costs the hospital are, we want wages to increase for the healthcare workers, right? And so their wages are a functional part of the cost of delivering care. We have to buy medical equipment. The profits of medical equipment and the drugs that we buy at the cost that we get them, their profits are baked into the charges of hospitals. And then the insurance, how much, right, there's charges versus cost, because and then how much will we get reimbursed based on the payer. So it's a complicated math problem with trains in different directions and when are they going to meet in the center. So it's really very challenging, but it is something we need to address as how. Now, I'm not sure about your question about we're not incentivized to lower costs because there's the cost to charge ratio, and I have to think through that. Of like how
Cost to charge ratio impact
right.
in terms of if you lower costs.
So if you lower cost in the cost to charge ratio, you're reporting your financial assistance and you're at the cost of what it costs the hospital versus what you got reimbursed. So it would actually, if you lower costs, it's going to lower the amount of financial assistance. I would say, though, your margin is going to have a bigger pressure on lowering your costs because you're going to want to keep your doors open. But yeah, interesting.
I just, thank you. I would just re-emphasize that when you're thinking about the overall expenses, cost is sometimes an ambiguous term. People use cost, it's sort of like, milk costs a lot, but do you mean a gallon of milk costs a lot or your monthly allocation for milk is a lot? Depends how much milk you drink, And so when we're thinking about hospital services, it's the price times the volume. And we can talk all day about price, but volume matters a great deal. And when you can prevent people from needing to come to the hospital, you can save a lot of money and not worry as much about the price. I think Marilyn has demonstrated that to be the case. And if you're thinking about, well, we want to control costs, you should focus on expenses, not just price. Price can be a part of the strategy, but you have to think about it broadly. And if you think about community benefit, what you're trying to do is trying to prevent people from getting sick. It's a volume strategy. And if you can pull that off, then you'll have lower costs, lower expenses.
This is going to be more of another question for discussion rather than an actual question.
Sure.
I don't want to point at this poor woman over here, but she's really started a firestorm. So, again, I'm an emergency physician, and I've thought a lot about, this is kind of a vague, but like there's fee for service, there's a big move towards value-based care. We talk about price and cost, what does it actually cost the hospital to deliver a service versus how much are you charged as an individual person. But in my line of work, we also have the cost to the hospital and our physicians of staying open all the time regardless. I could have 0 patients come in on a shift, which would never happen, but we would still need to be there. And the example I just gave somebody else is I was working overnight the night the Key Bridge collapsed. And we didn't end up getting any patients for a variety of both sad and happy reasons. Very few people actually were hurt, but all of them died, and so none of them came to us. But we were prepared for an influx because we heard about the accident. And we very quickly mobilized our disaster plan and had all of our trauma bays open. We had all of our physicians and trauma surgeon and ORs staffed and ready to go. In that case, we didn't need it, but we always need to have it available. And when you said the term baked in, you were talking about, I think, maybe some other costs, but we are baking in our readiness costs into the fee for service that we charge individuals for services too. And I'm more and more intrigued lately by this idea of treating at least emergency services as a public utility aligned with like the fire department or ambulances, although ambulances are a mixed bag too. But like maybe some degree of our emergency preparedness should not be in the form of payments that we receive from individuals that have an upcharge of $1,000 for Tylenol makes us look ridiculous. But like nobody minds paying me to sit there in case the Key Bridge collapses. Like I've never heard anybody resent me for that, but they do resent me for the $1,000 Tylenol, neither of which I have responsibility for. Anyway, just food for thought.
Other. Somebody over here?
Yeah, I would just second that thought about those capacity payments. I think that's one we've been looking at as well with emergency. We see it with OB in rural areas, but also, again, that surge capacity in case of emergencies. And I guess I just want to flag, it's a really big area where we need research to better understand different payment models to sort of think about that type of capacity payment. I know the emergency physicians have been sort of exploring new things. We're exploring some new models too, but I'm not a researcher, so if anyone wants a project and wants to help us out, we'd love to sort of think through that. But this is where what's more useful, is sort of picking a particular problem and really understanding the different drivers of the cost and where we can, align our payment systems to better get the value we want, I think is where I'd like to see, more of our research focused. And so thanks for raising that.
Great. Well, thanks for such a great discussion. I'll turn things back over to Hussein.